treating patients who are older and have breast cancer is not altogether straightforward, and there seems to be a lack of guidelines. What were you doing in the study that you've just been talking about here?
What we have been doing is we collected data from cancer registries, that could be either regional registries or national registries, and we looked at data on the one hand for treatment, so we found we looked at differences in surgical treatment and adjuvant treatment, and then on the other hand we also looked at survival outcomes of those participating countries or regions.
And it's quite a big study, isn't it?
It is, yes. We were able to include almost 120,000 patients with breast cancer, with non-metastatic breast cancer, I have to say.
And 6 different countries?
6 different countries, yes.
What did you find?
Well, it was interesting because we looked, on the one hand, we looked at treatment, the number of patients who received a particular kind of treatment, and we looked at local regional treatment, so surgery, auxiliary surgery, and also radiotherapy. And we also looked at adjuvant treatment, so the percentage of patients that received adjuvant endocrine treatment or adjuvant chemotherapy. And when we look at local regional treatment, the major differences were found in the patients receiving no surgery, because there is a part of all the patients that does not receive any surgery, and it differed across stages across different countries.
Right, so with no surgery or reluctance to use surgery or late diagnosis or whatever, what was the effect of that?
Well, it's hard to say because breast cancer treatment is and outcomes are dependent on like many types of treatment, so not only surgery does say something about the outcomes, and not only chemotherapy does say anything about the outcome, but what we did find was that there are major differences on the one hand in local, regional and adjuvant therapy, and we also found that there are major differences in breast cancer survival across different countries. And we looked for patterns, so it's hard to say there's a direct association, but we looked for patterns across the different countries and different survival outcomes, and we found that especially for stage 2 and 3 disease, more adjuvant therapy was linked with a better outcome.
Right, now that's one thing that seems to be floating to the top. It's always difficult to make a kind of league table of countries, which one is doing better. But tell me, which one was doing better?
Oh, the country that was absolutely doing better at all stages of disease, because we looked at stages of disease separately, was Belgium. And the one that was performing worst was the UK. And we already knew that the UK was doing better overall in cancer treatment, but we also find it in all the patients with breast cancer now again.
Now, I know that yours was a population-based study, and you can't say anything about causality. You have got strong information about associations. What do you think might be the factors giving Belgium this great performance and giving the UK this awful performance?
I think it's a very hard question because outcomes are depending not only on treatment but also on access to healthcare, also on time of diagnosis, patient preferences, doctors' preferences. So I think it's very hard, but of course treatment is a major part of breast cancer outcomes, because otherwise we shouldn't treat patients at all. And I think it's a hard question to answer, but I feel that more adjuvant therapy leads to better survival.
So in a nutshell, the Belgians are doing well with organisation and delivery, are they? And also giving more systemic therapies or adjuvant therapies?
Yeah, Belgium was giving definitely more systemic therapy compared to the Netherlands, and they were doing much better than the Netherlands. So Belgium was less conservative in treating all the patients. So that could be a reason that they perform better.
And what could be the logistical barriers to treatment that might be holding back the success of outcomes in other countries then?
Well, the major problem in treating older patients is there is a lack of evidence for treating them, for how to treat them. And I think in the Netherlands we are quite conservative, and we are very anxious that when we give older patients chemotherapy, they will experience lots of toxicities and adverse events, and we are withholding that treatment from patients while there probably is a specific population, older group of patients that is benefiting from adjuvant therapy.
So if you were to sum up the kind of guidelines that you might make provisionally, of course, because it's not your job to have the last word on it, for non-metastatic breast cancer in older patients, what might those provisionally be? Briefly.
The major thing is that you should not treat patients according to their biological or chronological age, but you have to get a better idea about the physical functioning and the fitness of the patients and treat them accordingly to that. So if you have a very healthy older patient, you should treat them according to the normal guidelines. Well, when you have a very frail patient, you might be doing a better job with holding certain types of treatments. So that would be my general advice.
And how big are the gains that you can make from this in terms of overall survival? Is it a big difference, or are we talking about details here?
I think especially when you're looking at stage 3 breast cancer disease, you see that the differences in breast cancer specific survival across the countries is over 10%. So I think there's at least an increase for 10% to make when we use the therapy we already have, like the current therapies, in a better way for all the patients. So I think there would definitely be room to improve survival outcomes in all the patients. For us, the reason to do observational research instead of randomized controlled trials is because we...
Shall I ask you? Shall I ask you that question?
Sure.
And your reasons for doing observational research rather than randomized controlled trials?
We have several reasons for that. First of all, we know that in the current randomized controlled trials, not many older patients are included. And we also know that the older patients that are included in randomized controlled trials, they are much healthier and have a better prognosis compared to the general older population. So the good thing about observational research is that we include all patients, which makes it more representative for the general older population, and therefore, and by doing that, we have a better overview of how to treat older patients.